everyone. Thanks very much for having me on. Thanks very much to the Northern Beaches Mums Facebook page for making this event possible, and also to Northern Beaches Hospital who've helped out as well to get this together. A little bit about myself. So my name is Hugh Porter and I'm an obstetrician and a gynaecologist. I have the very good fortune of working at the Northern Beaches Hospital, which is presumably your local hospital if you're on this live stream. I'm just going to check this comment section's working. Great, yeah, they're good. I can see some comments and things coming through now. Fantastic. So yeah, basically a little bit about myself. So I started out, funnily enough, as an engineer, and I did a degree in physics as well. So I wasn't always a doctor. Started off doing that, and then worked as an engineer briefly. Didn't love it, and then somehow transitioned into this amazing world of medicine. And now I'm just extremely passionate about what I do, which is to help deliver babies, and it really is an amazing career. I've done a few other things. I worked as a ski instructor. I love my skiing. I did 4 ski seasons in America. I worked in the Whit Sundays as a flying trapeze artist for a little while. But as I say, I've really found my vocation now, and I couldn't be happier. So it's my absolute pleasure to be here tonight. Thanks for joining us. A little bit more about myself. So I am a husband and a father. My wife is one of the proud members of this group of the Northern Beaches Mums, and she actually works at the Northern Beaches Hospital as well. She is a medical oncologist at the hospital, so she works in cancer, and we do sort of talk about the fact that we have very different jobs. She's working in this incredible industry where she has to break bad news and talk to people that have cancer, and it's a very, very trying, difficult job sometimes, whereas I always think I'm very fortunate in what I do because I get to help give someone a beautiful new baby. It's a very happy specialty most of the time, so I'm very, very fortunate in that regard. We do have 2 children ourselves, hence why my wife's in the mums group. We have a beautiful almost 3-year-old boy, Nettie, who is just amazing. He's wonderful, and we've got a 5-month-old little girl, Hallie, and she's pretty cool too, which is really nice. So I guess we'll probably get on with it. So I will. I do have some notes here. I'm going to talk about a few different things tonight. Got a few topics to talk about, but really at the end of the day, what I'd love is to get some questions and comments from the group. That would be really nice, because otherwise it's just me, talking at you the whole night, and I think it'd be far more interesting for everyone if we actually get some questions on to ask for me to answer. But if not, I'm here to talk about some topics. So in particular, some stuff that I find really interesting. So the first topic I'm going to talk about is VBACs, which is vaginal birth after caesarean. I'm going to talk about this amazing new trend and this amazing new concept of a maternal assisted caesarean section, which people find quite interesting. And I'm also going to talk a little bit about some pain relief options in labour. And I guess if you wanted to put a topic on the whole talk, or a theme, the theme is I want to help women feel empowered, feel like they are taking some control of their birthing experience, because there's been a lot of media attention on obstetric trauma, birth experience, people losing, medicalisation of the labour process. And I guess in talking about maternal assisted caesareans and vaginal birth after Caesars, that's really what we're talking about. It's basically giving power and empowerment back to women for their birthing experience, and I'm quite passionate about that. So hopefully they're interesting topics tonight. And as I say, if you have any questions, I'd love for you to fire them through. In terms of my practice, so I do work as a private obstetrician at the Northern Beaches Hospital, but I also work in the public system there as well. So I've experience on both sides of the fence, and we're very lucky. I mean, you guys are so lucky to have literally on your doorstep one of the most new state-of-the-art facilities with all these options available to you, different models of care and things like that, which is fantastic. And I'm happy to answer any questions tonight about the different models of care that's offered at Northern Beaches and how we can help you. I do also practice on the North Shore, so I have consulting rooms physically in the Northern Beaches Hospital, but also at North Shore Private Hospital and the Mater, where I deliver babies as well. As I say, I do work publicly as well at the birth unit at Northern Beaches Hospital, so I do get this really nice mix of public and private work. I am, as a private obstetrician, I'm on call for my patients 24 hours a day. I give my patients my mobile telephone, and I do, and I'm there for you basically if you come to see me. Some of my interests specifically are in preconception counselling. So I'm really passionate about people who are trying to get pregnant, and I can try and help out in that respect. I like low risk pregnancies. I also really like high risk pregnancies, and I trained at Westmead Hospital, which is one of the busiest birth units in New South Wales, with some really high risk obstetrics being done there. So have quite an experience in the broad range like that. I like twin deliveries, especially vaginal twin deliveries. And look, I'm happy to answer any questions tonight on any topic that people want to throw at me. But in the absence of any questions, I guess we'll probably get started into the topics that we'd like to talk about tonight. So, before I do go on, just I do want to give a quick plug for the hospital. It really is an exceptional hospital, and I guess one of the things is that no matter who you choose as your care provider, be it public or private, or midwifery, whatever it is, you're very, very lucky at this hospital because there are fabulous midwives, some of the best in the state. We've got an amazing group of obstetricians. The whole bunch are just incredible. So it is a very lucky place. And also a little bit of a shout out to the women of the Northern Beaches, because I'm so fortunate to be able to work with this demographic of very well educated, very well informed women who are interested in their birthing experience, well read, and they do love information, and that's sort of my passion, is education information. So I'm very lucky to work with a group of women that are interested in what's going on. So as I said, tonight we'll talk about VBACs, vaginal birth after Caesar. We'll talk about maternal assisted caesarean sections and pain relief in labour. And also, if you're interested, I do have an Instagram page where I'm sharing a lot of pregnancy tips and things. So feel free to follow me. It's at Dr. Hugh Porter, and you should be able to find me on there. So let's get straight into it. Let's talk about VBACs to begin with. So what is a VBAC? What we're talking about is VBAC literally stands for a vaginal birth after caesarean. Okay, so this is for women who have had a caesarean section, okay, and it doesn't matter what the reason is, that are then pregnant again with their second baby. And what we're talking about here is how are you going to have your second baby. Okay, now you could straight away just decide to have a second caesarean section, and there's absolutely nothing wrong with that. But I guess as the topic here about feeling empowered in your labour and your pregnancy, giving women the option of thinking about potentially doing a VBAC is a great option. So tonight I'm going to talk a little bit about say the pros and cons, some of the risks, some of the benefits, who's a good candidate, that kind of thing. And as I say, any questions you've got, feel free to flick them through. Okay, so in terms of the pros of a VBAC, okay, the major pro is that you're going to avoid a caesarean section, okay? Caesarean sections are wonderful. We do them a lot, okay? The rates are up to about 37% now in New South Wales on the last survey, which means that a lot of people have had one and therefore going to get pregnant again. But therefore the advantage of having a vaginal birth after caesarean is that you can avoid having this big sort of cut on your tummy and the recovery that comes with that. So it is a big operation. It has risks, damage to your bowel, bladder, blood vessels, nerves, all that kind of stuff. And having a nice natural birth after one caesarean section can be really beneficial for your recovery, for your breastfeeding, for your bonding, all those kinds of things, back on your feet really quickly. What are the cons? Why would we not have a vaginal birth after Caesar? Well, really the big one is just the risk of something bad happening, okay? And I'll go into a little bit about what those risks are. Now, just remember, I guess we do have to say that the risks are very general. I don't know your individual circumstances, so I'm going to kind of talk about it in very broad strokes. But if you want to have some more information, book in to see one of the fabulous healthcare providers at the Northern Beaches, and we can talk you through all your options, be it public or private. So who is a good candidate for a vaginal birth after Caesar? Basically anyone who's had a caesarean section before, okay? There are other options available to you. As I said, you can have an elective caesarean section, you can have a maternal assisted caesarean section, which is, we'll talk about that as well, and then you can have a VBAC. So how do you know if VBAC is for you? Well, the first question I sort of basically like to answer is, do you fit what we call the safety criteria? Are you actually a candidate for a VBAC in the first place? So we've got to have some rules about whether or not it's safe to do. So the kinds of things we look for are, and bearing in mind, it does depend a lot on your individual circumstances, but broad broad strokes, we're talking about, number one, what happened in your first birth. That's really important. So I like to see the operation report from your first caesarean section to make sure there wasn't some big surgical complication, say a big tear out to one side, something that would mean that by the way they had to repair it, there's a weakness in the uterus that we'd be worried about. Now, 99 times out of 100, the caesarean section's uncomplicated and it's not a problem, but I do like to chase down that operation report and know you're safe. We do like to have 18 months between babies, okay? No one really knows how long it takes a uterus to heal when you sew it back up, okay? But we do like to have 18 months because we think in 18 months, that uterus, that muscle of the uterus where we've sewn it up is gonna be at its full maximum strength. When we actually do it, it's a bit of a technical thing and we can check it on the operation report, but we like to check that you've been closed up in 2 layers. And that's something obviously that just gives a bit of extra strength to the scar. Size of your baby is interesting. Okay, so we know really small babies don't tolerate labour all that well, and we know really big babies can physically not fit. So if you're at either end of the spectrum, really wide on either side, then we take that into account when we're deciding if you're suitable for a VBAC. We have to be happy to have monitoring in the pregnancy. So we need to be able to watch your baby's heart rate at all times during the pregnancy, during the labour, which means having the CTG, the continuous monitoring on your tummy at all times. Okay, so that's really an important step. It's important to deliver a baby at a hospital that has facilities to help you out if things aren't going right. And that basically just means access to an operating theatre, especially overnight if you do go labouring into the night. Okay, and we're lucky at the Northern Beaches because we do have a team on standby if we had to perform an emergency caesarean section overnight. And the other thing too is just to make sure that you're a suitable candidate for a caesarean in the first place. For a vaginal birth in the first place. Like, for example, you don't have any complications like a placenta previa or the placenta covering your cervix, or a really small, baby that's not going to tolerate labour. So I guess if we know you're a good candidate for a VBAC, then the next thing to ask is it going to work? It's really important, okay? Because if it has a 5% chance of working, is that really what you want? So the way I sort of explain it to my patients is, if you've had a previous caesarean section, I know nothing else about you, your chance of having a successful VBAC is somewhere between 60 and 70%. That's pretty good odds, right? That's pretty good. It also means that somewhere between 30 and 40% of the time, you'll end up having a repeat caesarean, but 60 to 70 is sort of like a baseline benchmark to start with. Now from there, we can go up or down in your success rate. So I talk about whether you're going to be more successful than the average or less successful. Now, the kinds of things we take into account to work that out is what happened in your first pregnancy. So for example, if you've had the best indicator of having a vaginal birth after a caesarean, if you've actually had a successful vaginal birth before, because then we just know everything works. So this would be the patient who had a beautiful, nice vaginal delivery in their first baby, second pregnancy, baby's heart rate didn't like it, there was some cord around the neck, whatever reason they had to have an emergency caesarean section. Now it's the third baby, but we know everything works, you've done it before, and those people's success rates can be up to 90% plus, so they're fantastic candidates for a vaginal birth after Caesar. The size of the baby is going to change the success rates. As I said before, if you've got a really big baby on board, then it's probably going to be less successful than if you've got kind of an average size baby. And again, a really small baby can actually decrease the success as well, because those babies just don't tolerate labour as much. The indication for your first caesarean section is important too. So did you have the caesarean section because that particular baby in that particular labour wasn't enjoying it? It was to have a really bad heart rate and we had to do it for your baby. It wasn't a problem with how the labour was going, it was just that baby was irritated. So that's a better indicator and your success rate actually goes up. On the flip side, your success rate will go down a little bit if your baby got stuck. So if you laboured all day and your cervix stayed 3 centimetres and nothing happened, then your success is probably less than that 60 to 70% rate. If for example, you got to fully dilate it and you pushed really hard for a couple of hours and baby's head just never came down, your success this time around is going to be a little bit less than that 60-70% too. And that's basically because it might mean that your pelvis is a funny shape, maybe the baby was in a funny position, something along those lines, but that can often mean it can happen again. Now, of course, none of these things mean that you can't try for a VBAC. It's really just looking at it and saying, hey, is this going to work? What are my chances here? Do I really want to go for it with these kind of numbers? Some things that would make your success a little bit less would be if you have what we call a really high BMI or you're quite obese. Then we know the success rates are lower. At extensions of age, so as you approach 40 years old, the rates are probably slightly less. And also, as I sort of said before, if we thought it was cephalopelvic disproportion or there was a problem with the way your pelvis is shaped, then that can obviously affect it with the second baby as well. And then the final thing to talk about is, do you need to be induced or are you going to labour spontaneously? So your success rate is going to be higher if you go into labour spontaneously. You just turn up in labour, fantastic. If we have to induce you, and we'll talk a little bit more about that, then maybe your success rates might be a little bit lower. All right, so we've got to talk a little bit about the risks of a VBAC. That's really important because going into something like this, it's really, really critical to understand what could go wrong, okay, so that you can have this, what we call informed consent. At the end of the day, it's your body, it's your baby, and I'm a really firm believer in you get to choose how and why and whatever happens in your birth. It's really my job to educate and to help you make a decision based on all the evidence and then letting you do it. And people have different risk profiles, so I just sort of let you know what the risks are and let you choose how much of that's material to you. So we know that the biggest risk in a VBAC is that something's got to open for your baby to come out. So it's either your cervix is going to dilate to 10 centimeters or the scar itself on the uterus is going to start to open, and that's not what we want. That's called a uterine rupture, and that's the worst thing that can happen and the biggest risk you've got having a vaginal birth. So in that case, okay, what we talk about is the risk of that happening, and it's actually relatively low. So for anyone trying to have a vaginal birth after Caesar, your risk of having a uterine rupture, we quote as about 1 in 100, okay, which increases to 1 in 200 if you need syntocinon for induction of labour. Sorry, other way around. 1 in 200 if you labour spontaneously and 1 in 100 if you need syntocinon. If that actually happens, if your uterus was to, start to break apart, then you need to get to the operating theatre really quick, and that's when something bad can happen. And we quote the rates of either cerebral palsy or something worse, fetal death, as about 1 in 10. But when you put all those numbers together, it's low risk. We talk about 1 in 2,000 of something really bad happening, which is very, very low, and 1 in 1,000 if you need syntocinon. And that's why we like to offer this. We want to offer people options for normal birth if, 1 in 1,000 is not that risky for you, and that comes down to how you value risk. So how can we make that risk less? That's kind of our job as obstetricians, is to help provide ways for you to have a less risky birth, okay? And that would be approaching it in a sensible way, okay? We know that labours that are progressing well, the cervix is opening, we're checking, everything's going well, the head's coming down, we know that's a really good sign. We don't like it when the cervix gets to, say, 6 centimetres, 4 hours later, it's just stopped and stalled right there, and that's when we start to worry. So when we approach it sensibly, the way I sort of approach it is, look, if everything's going really well, let's roll with it. This is great. But you've got to have some sort of line where you're going to say, at what point are we going to bail if it's not going the right way and end up having a safe birth as opposed to a really crash emergency Caesar kind of birth. So other things we can do is have a maximum rate of syntocinon, the hormone drip, and that's going to stop overcontraction of the uterus. And also we need to do continuous monitoring of your baby. So sometimes we put a little clip on to monitor the baby's heart rate, and definitely the CTG during labour. And when we start to see problems with the baby's heart rate, that's when we would think about, thinking about a Caesar earlier rather than later. So I did see a question coming in there. That's great. I'll get back to that in just a minute. So I guess now I will answer some questions now. So I've got one on here. Does your risk of uterine rupture increase with the amount of caesareans you've had? That's a fantastic question, and one we get a lot. So generally speaking, most of the studies that have been done, and then we base all of our counselling and evidence off some studies that have been done, most of them have been done on someone who's had one previous caesarean section. Therefore, the best knowledge we have and the best way we can counsel you about risk is to tell people who have one caesarean section what their risk is. If you've had 2 caesarean sections, there are some studies, they're a whole lot smaller, but that do suggest actually the risks are relatively similar. So it's not more unsafe to have a VBAC if you've had 2 caesareans. That being said, you still need to find a provider who's comfortable to do that. And that can be challenging. there are very few circumstances where I'd be very comfortable to offer someone who's had 2 previous caesarean sections a normal birth. That being said, there are certainly cases where we've done that before, so it's something to have a really good chat with your healthcare provider. I would suggest that using common sense, the more caesareans you have, the more risk of having something happen to the uterus. But the studies would suggest that 2 is probably okay if you can find someone who'll look after you. So other questions I had, so does your provider offer it? So I guess when you are booking in, we do have a VBAC clinic at the Northern Beaches Hospital for the public patients, which is awesome, run by one of our fabulous staff specialists. So that's really good. It does depend a little bit on when you actually come in labour, which consultant is going to be looking after you on the day. Everyone has a slightly different risk profile and risk acceptance as a doctor. So some people will have a lower threshold to suggest a caesarean section, but you certainly you should talk to your healthcare provider. If you are thinking about a VBAC, try and pick someone who's sort of aligned with you, who's aiming for the same sort of goals. What about, would you want to have an induction? Well, that's a personal choice. Induction does theoretically double the risk to you, but we're really talking about changing the risk from, say, 1 in 2,000 to 1 in 1,000. So induction of labour is still relatively safe. I offer induction of labour to people who are having a VBAC under certain circumstances. And again, it's finding a provider that's going to help you align with what you want to do. There are some other sort of hybrid models you can think about. For example, if you didn't want to have an induction, you might say, I'm going to labour all the way up to 41 weeks, and if I haven't gone into spontaneous labour, I'll book a caesarean section at 41 weeks. We do that kind of thing sometimes. Other questions. So I got asked a question about scar thickness on ultrasound. So some providers will do an ultrasound at around 34 weeks to look at how thick your physical scar is from your previous caesarean section. Now the evidence is pretty thin, no pun intended, for that. I don't personally do it, but look, some providers do look at the thickness of your scar. Bath in labour, I would advise against getting in the bath in labour if you're having a VBAC, because if anything does happen, we want to be able to help you straight away, and we don't want to be messing around trying to get you out of the bath. I do have another question on here. Is there anything a mother can do to help support successful VBAC, e.g. diet, exercise? Another fantastic question. Thank you for your question. I really appreciate it. Absolutely. Yeah, look, we know that things like obesity, okay, will decrease the chance of a successful VBAC. So there's no question that body tissue is better if you're fitter, stronger, healthier, okay? So by eating all your vegetables, doing some exercise, this kind of staying as fit and healthy as you possibly can, you're going to optimize the tissue in your body, and we want your tissue to be at the most supple, strong kind of tissue you can have. So absolutely, you know, a happy, healthy pregnancy is going to be your best bet. There are some things you obviously can't modify, like the shape of your pelvis. You can't change that. You can change sometimes the size of your baby. So whilst diabetes isn't something you can control, you can control your sugars by diet and using medications and things. So certainly that's going to avoid baby getting bigger and potentially getting stuck, which can impact the success of a vaginal birth after caesarean section. Now, twins, generally most people are going to recommend against a VBAC if you're having twins. And I guess one final question that I got about this before we move on to the next topic is about this sort of cascade of intervention. And, you know, I guess people who are thinking about having a VBAC are often doing that because they missed out on something the first time. They really wanted to have that natural normal birth, and they ended up having a caesarean section. So one thing you do need to take into account is that if you do try for a vaginal birth after Caesar, whilst I said, say, 60-70% of the time it works, remember that also leaves about 30% of the time where it doesn't. And in that 30%, you are more likely to have some of these interventions, you know, scalp clips, you're going to have emergency Caesars, all that kind of stuff. So there is a slight chance of needing more intervention if you do go down this pathway. So it's kind of like you're either going to get your normal birth, or there's a good chance you're going to end up with a fair bit of medicalisation in the process, and that's just something to take into account. So that kind of covers everything that I wanted to talk about with VBACs. I'm happy to take any more questions, but I can't see anything on there now. So what I'll probably do is move on to a really exciting topic, and one that I'm excited to talk about, which is maternal assisted caesarean sections. Now, we're really lucky at the Northern Beaches Hospital because we can offer this exciting, relatively new procedure, okay? Now, what is a maternal assisted Caesar? I get asked this a lot. Basically, this is putting the birth back in your hands. Okay, this is for someone who wants to be empowered, in control, and wants to be involved in their birthing process, but for whatever reason needs to have a cesarean section. So how do we combine being in control and being empowered with having a cesarean section? Well, we've sort of developed this thing called a maternal assisted cesarean section. Basically, so people do, like, people who've had these, the women that we've done this for, have had a fabulous experience. The feedback is incredible. Just that feeling of being able to hold your baby and really essentially bring your baby into the world. So who does this apply to? Who is a candidate for a maternal assisted cesarean section? Well, this is people who wanted to have potentially a vaginal birth but can't for some reason. For example, they've got maybe like a placenta previa, which is where your placenta is covering the cervix. So you have to have a cesarean section in that case, but you really want to be involved in that birthing process. Often people who've had a traumatic first birthing experience, okay, and we're seeing more and more of this research about birth trauma and the importance of being in control of the whole process is so important. And then also people who feel like they kind of just lost control in their first birth. They were in control, they had a plan, and it just, over the course of the day, it just kind of slipped away from them. And suddenly they're in the bright lights having a cesarean section, and it's all just too much. So these are the kind of perfect candidates for this kind of procedure. So I kind of wanted to just actually go through with a maternal assisted Caesar with you guys, and just explain what it is, because it's pretty cool. So basically what we do, okay, we meet mum in the anaesthetic bay, and we have a bit of a chat, check how everything's going, make sure baby's got a nice heart rate, and we're all good. Now this is an elective procedure, so this is being booked months out. Our team's aware, the theatres are aware, everyone's excited, mum and dad are there, and basically we then we take mum, and instead of going and sitting on the bed for the spinal anaesthetic, which is the first step of a normal cesarean section, we actually go around into the next bay, which is the scrub bay. And this is where we get to both play surgeon. And really, so what we do is we physically do a surgical scrub together. So myself and my patient do a surgical scrub together. So what we do is we, sleeves get rolled down, okay, and we scrub, and I show it's about a 5-minute scrub, scrubbing each side of the fingers, under the fingernails, multiple times, and I explain how a surgical scrub works. And the best way I can explain it is I do this all the time for medical students who've never scrubbed before, so anyone can learn this stuff. We then, okay, once we've got nice clean hands all the way down to the elbows, obviously no watches, no rings, we go into the theatre, okay, holding the hands up like this. We then put some nice long gloves on mum to protect and make that whole area sterile. So mum's now got this beautiful sterile area covered in gloves, and from there really you can touch whatever you like, because what's underneath is sterile. Mum walks around, sits up on the bed, and gets ready to make that sort of prawn shape, getting ready to have the spinal anaesthetic in the back. So in goes the spinal anaesthetic. The anaesthetist does that for mum, okay, and very quickly, it works within a couple of minutes. We lay mum down. We then, lying down, have the hands up in the air like this. And we carefully take the gloves off, and that leaves us with this beautiful sterile area in mum's hands and arms like this, okay? We then get the surgical gown, okay, exactly the same kind of gown that we were, myself and the assistant are going to wear, and we put the gown on over mum, she's lying down, and then we put gloves on as well. So now mum's got this beautiful sterile area on the front and the arms and the hands, and that's when the hands go on the chest like this. You can imagine lying down, getting ready to have your cesarean section. Now from there, it's pretty much just a regular cesarean section from my point of view. So we go down, we paint the tummy, we put the drapes up, we still put a screen up so you can't see anything. You can sit there and have a chat with your husband, with the anaesthetist, getting ready for the whole thing. And then we go around. It's very quick to get your baby. So what happens is we cut down, we get to where baby's head is, okay? And then just as I'm starting to deliver the head, that's when we drop the drapes so mum can have a look over the top, and with the hands then can actually physically reach over, and we've got this beautiful sterile area that's continuous all the way to where baby is. Now I get mum to make this kind of gun shape with the hands like this, and as mum reaches down to the tummy, okay, fingers go just under bub's armpits, and then mum can help actually bring baby up out of her tummy and straight onto her chest. So the first thing that happens is mum actually physically brings baby up and on, which is just a wonderful experience, and we love that. Now from there, once we're over the drape, we can do skin to skin, rip the gown off, baby straight onto the skin, delayed cord clamping, all the good things, okay? And the good thing is that we get about a minute there, regardless, where we can give baby a really good rub, start to get that nice cry, and we go from there. So if ever baby does need to have a little bit of breathing support, and that happens at caesarean sections sometimes, we've got that beautiful minute where mum's got bub on the chest, and then if we cut the cord, if we do need to go to the paediatricians to have a little bit of look over, they can do that. Otherwise, the very first thing that's happened is mum's physically lifted bub straight onto her chest, and it's a really lovely experience. From there, the drape goes back up, everything's sterile, and we finish the procedure. So it's a really, really nice experience. So I guess when we've got to talk about if there's any reasons you couldn't have a maternal assisted Caesar if you want one, really it's, unless you've got some sort of medical reason why you can't physically reach down and pull a baby out, you know, you've got a plaster cast on your arm, or you've got a wedding ring that won't come off and you can't scrub, there's really no reason why you can't try for one of these births. If the baby was to be in a poor condition that we didn't expect, if there was some complication and we really needed the baby to go straight from the tummy straight to the paediatrician to get some help, then we would probably abort. And I always tell my mums that are planning this procedure, we've got to have an exit strategy as well. Okay, there's got to be a plan where if things aren't going right, we've got to say, look, it was a great idea, but we've got to, and touch wood, we haven't had very many of those at all. Okay, if there's unexpected surgical complications, so if it's really difficult to get in, that being said, by the time we get to where bub's head is, there's very little reason why, if we can get baby's head out, that mum can't reach over and help deliver her baby. And then the other thing would be that mum actually wants to do it, okay? If you're not a fainter, you don't have a fear of blood and all those things. So you've got to be, you know, able to see a surgical site and those kinds of things too. Of course, in like anything, it's really important in medicine to talk about what are the other options. So the other options, if you've had a previous caesarean section, would be to have a VBAC, like we've already talked about, or to have just a straight up regular caesarean section. So like anything, like we talked about with VBAC, we've got to talk about the risks as well. That's really important. So what are the risks of having a maternal assisted caesarean section? Well, really the risk is going to be infection. That's what everyone talks about. That's what we're going to be worried about. The point is though, at Healthscope, who own Northern Beaches Hospital, we've developed a policy with infection in mind. And the point of the whole surgical scrub, I watch mum like a hawk to make sure the chain of infection's never broken, and everyone's keeping an eye on things. So infection rates, to our knowledge, are not increased at a maternal assisted Caesar. It's interesting though, there hasn't been any really good studies to say whether the infection rate is higher or lower, and that's actually one of the things we're working on at the moment, which is to do a research project in this to go and prove that this thing is actually as safe as we think it is. So I'm happy to answer any questions if anyone's got any questions about maternal assisted caesarean sections, so feel free to flick those through. I can see there's another question on here now. Can you go through how trial of labour works? What's the process? Is it risky for a woman in her 40th week with a closed cervix? Okay, cool. So this is dropping back. We've talked a little bit about VBAC, so I'm really happy to answer any questions, and I'd prefer to be answering your questions than me just talking at you. So thanks a lot, Jenny. The question is, can we go through how a trial of labour works? So presumably this is someone who's had a caesarean section before. That's why we're saying a trial of labour, and it's a really good way to think about it. In fact, in some centres they don't call it a VBAC, a vaginal birth after Caesar. They call it a TOLAC, a trial of labour after caesarean section. So what we're really doing is trialing it, okay? And we think about it in those terms. We say we are going to see how we go here. And as I kind of like alluded to before, if things are going well in labour, things often just keep going well, and then you just have a baby. It's like, that's kind of how it works. It's really when we deviate from the path. So when you said, is it risky for someone in the 40th week with a closed cervix? There's two things in that. Is it risky? Well, your risk is pretty much the same once you're in labour, depending on whether you went into labour spontaneously or where you needed syntocin on. Now, if you've got a closed cervix at 40 weeks, there's a pretty good chance you're going to need an induction of labour. Okay, with a closed cervix, we're going to need to get that cervix to open before we start your trial of labour. Now, that's not to say we can't do that. It just comes back to what we were saying before about what are the success rates? What are the chances of it actually working? Now, if you have a tightly closed cervix, we need to do a lot more. You need more preparation of the cervix, more syntocinon to get you into labour. Your labour is going to be longer, and with longer labours, your success rate's going to drop a little bit. But it's not to say it's not worth trialling. So I would definitely still not say don't do it on account of that. I would still say go for it, and then we just use those safety markers we talked about before, the continuous monitoring, the low threshold to abort if we need to, that kind of stuff, and then go from there. I've got another question on here from Elsa. Thanks, Elsa. As I say, keep the questions coming in, guys. Let's have a little look here. So, thank you for this interesting talk. I had an emergency C-section for my first baby. I'm due on July 9th. I've developed gestational high blood pressure. We've booked an exit plan for next week. For now, we're looking at induction with the balloon. Could I be a candidate for assisted maternal assisted Caesar? So, at the end of the day, absolutely. Almost everyone, like I said before, could be a candidate for a maternal assisted caesarean section. There are some things to think about, so it depends a little bit, without knowing your circumstances. We want to see what your first caesarean section was all about. So I'd want to go back and have a look, make sure that we're not going to run into any crazy sort of scar tissue or anything funny like that. But generally speaking, it's pretty safe to go for it. It depends a little bit on your model of care. So, I mean, if you're already this far towards the end and you haven't planned that yet, it depends a little bit on your provider. If you're going through the public system, it's very difficult to organise a maternal assisted Caesar, especially late in the piece, because there's so many pieces of the puzzle that need to come together to make it work. It's very challenging to get that sorted out in the public system. But certainly the fact that you've got blood pressure is not an issue. That there's no reason we couldn't do it for that. I would say, and I'm not sure if I really said it before, but it's important to remember that a maternal assisted caesarean section needs to be a planned event. Okay, we need to go, you're having your caesarean section next Thursday, and the reason that is that we need to pick an anaesthetist who's on board, a theatre team that's on board, a time of the day that is going to work because the caesarean's physically going to take a little bit longer, and an operator that's keen to do it. So you need all of those things to align. So sometimes I would suggest, if it hasn't been planned and you're late in the piece, Elsa, it may be challenging to organise that at this stage. It's certainly a question for your healthcare provider. I would say it would be difficult if it's in the public system and you're already down that track. The other problem can be that if you have developed complications in your pregnancy, that you might end up needing to be delivered a little bit earlier than planned. So with all my private patients that we're going to organise maternal assisted caesareans for, I always say, look, as long as it happens on the day we've planned, at 39 weeks, for example, everything's fine. But if you come in labour 2 days before, it's 2 o'clock in the morning or even 10 o'clock in the day, and we have to do your caesarean section, then unfortunately, all bets are off, because we just need to have all those cogs working together to make it work. So I hope that helps. Obviously, you should just have a chat with your healthcare provider there at the beaches and see what's going on. It can be challenging that late in the piece. So some other questions about maternal assisted Caesars that I've been asked in the past. What if your baby's breech? Well, unfortunately, a breech delivery means your baby's coming out butt first or foot first, okay? So much more challenging for mum to reach down and pull baby out because the head can get stuck and all sorts of things. So unfortunately, if you've got a breech baby, that would be one of the reasons you couldn't have a maternal assisted caesarean section. That being said, if you've got a breech baby, we can try and do something like an ECV, which is trying to turn your baby, say 36, 37 weeks from the outside to try and get your baby into the head down position. But if that's the case, you may be eligible for a vaginal birth anyway. Can we do delayed cord clamping? I'm a big believer in delayed cord clamping, so absolutely. If baby comes out in a good condition, as I say, we've got about a minute there when baby's on your chest while we're just rubbing baby up to make sure baby's happy, and that is a beautiful minute to get the delayed cord clamping. And if baby's happy, I'm happy to just keep letting that cord pulsate until it stops, and then we clamp it after that. On that, I actually got asked today by one of my private patients about whether you can have cord, if dad can cut the cord, and unfortunately it's only mum that's scrubbed in the operation. So once the baby has been passed over, we can't do anything back in the sterile field. So unfortunately, dad can't cut the cord as part of the operation, but what we can do, and what I do, is leave the cord a little bit longer. Okay, we put like a metal clamp on it, and then when dad's ready, we put a proper clamp on, the proper plastic one, and dad can trim it off, which is a nice way to be involved as well. The resuscitator, so we should mention the fact that with a maternal assisted Caesar, baby sometimes does need to go to the paediatrician to be looked over. So sometimes they do need a bit of a rub. But as I say, that first minute's really important when you can give Bub a really good rub and get that cry out of baby. And if baby's crying well, there's no reason for baby to go to the resuscitator early on in the piece. I've got another question here. Are there any risks besides infection with the maternal assisted C-section? Look, the main thing is, thanks Jackie, the main risk is going to be infection, as we've said. So like what you've put in brackets there is besides the usual C-section risks, and that's what I would say for anyone having a caesarean section, there are the usual risks. So the way I sort of explain it to my lovely private patients is that you can have damage to any of the structures in your tummy. At the end of the day, we are cutting into your tummy. We do these things day in, day out. It's a very, very safe procedure. And if you think about it, it's the most commonly performed laparotomy in the whole world. So when we cut in, you can damage bowel, bladder, blood vessels, nerves, all sorts of things, okay? But as far as mum being involved in the process, to my mind, the two risks are, one, things aren't going as well as you'd like and you have to abandon the procedure. That's probably the disappointing risk, be it because mum went into labour early and we had to do the Caesar as an emergency, or because of the way the actual procedure's coming, maybe it's difficult to get baby out, something like that, we have to abandon. So I always counsel my mums to say, look, there is a small chance, even though best laid plans, at the end of the day, a happy, healthy, safe baby is our number one priority. But I would suggest that other than infection, and we don't think that is a particularly more higher risk than the other Caesar, that your risks are that of a normal caesarean section. So that pretty well covers the caesarean section, the maternal caesarean section, and the VBAC as well. But as I say, if you've got any questions, if you've missed some of it, you can always go back. I do encourage you all to have a little look at my Instagram page. It's Dr. Hugh Porter, the Dr. Hugh Porter. Jump on there, have a look. I'm always sharing pregnancy tips and things like that. So the final thing I was going to talk about tonight, and it's 8:41, I'm sort of conscious that we've got about an hour here. The final thing I was going to talk about was some pain relief options in labour. And I think this ties in nicely with our theme tonight of empowerment in labour, okay? Because knowing how to control your pain is really important. Now, it's so individualised, the pain concept in labour. Really, like, you can never predict who's going to react how to labour, okay? And a contraction for one person is going to be completely different to a contraction in another person. And I've seen people come in, some of my private patients say, like, no, I don't want an epidural, I don't want anything, I'm just going to go all natural. And then with one contraction, like, get me that epidural right now. And I've seen it go the other way. People who I literally write in my notes sometimes, patient wants epidural as soon as they arrive, and then they come in and they're like, actually, this isn't kind of that bad. And then you kind of get into it and you get a few other strategies going on, and suddenly you've had a baby without an epidural. So we can't predict it. The important thing is to, like I always say, like, educate and understand what the options are. So you've got this whole toolkit. So you're coming into your labour having all the tools and knowing what your options are. So I thought I'd go through a few of those for you now. Number one, and I think the overlooked kind of pain relief methods are really the natural pain relief methods. So, like, oxytocin and labour and things, you've got to remember it is still normal, natural process, and we've got to push for that. And so when my wife was in labour and she had two beautiful normal vaginal deliveries, we actually did one of the proprietary courses that was really helpful to us. And funnily enough, even as an obstetrician, I got a hell of a lot out of that course. In terms of things like setting up the room for success. So little things like we had the dim lights, we had the flickering candles, we had the playlists, that kind of stuff. And having that preparation, that mental preparation for labour, I'm sure takes the edge off the whole thing. And it's having that real thought and control over your environment that's really important. So I really encourage my patients to think about their birthing environment, and for the people coming in and out of the room to be conscious of that birthing environment. And I think it really does impact on people's pain and satisfaction in labour as well. The mind is a bloody powerful thing. So anyway, we've got to remember that. Also on that point, courses as well. So there's some fantastic courses that are available. Childbirth is a fantastic course. Wolf and Cub do a really cool course, and also the Birth and Beyond are fantastic as well. So have a look. The Northern Beaches has all these great courses that can help. And it's like, as I say, like, we're all a piece in the puzzle. I'm an obstetrician. You've also got a midwife. You've got, your doula. You've got your antenatal courses. And what you really want to do is put all this stuff in together that give you the best option for success. Another really good pain relief strategy, and something that works probably better for your early labour phase. So a lot of people actually have this kind of like early labour at home. You know, you're walking around, my wife and I, for example, she was in this early labour for a good 24 hours. You know, she's having contractions. She can feel the contractions. They're not that strong. We're walking around our neighbourhood, stopping on fences occasionally to have a little breathe, that kind of stuff. Trying to delay the time to before we actually went into hospital to kind of reduce that labour time. And what she used, and she absolutely swears by it, was a TENS machine. So you may have seen or heard of these. These are like sticky little pads. They're about that size, and they go down on your lower back, and they're basically attached to a little machine. You can have it hanging around your neck, or you can pass it over. You can pass it over to your husband, and he can be pressing the button. And basically, when you get a contraction, you press the button. You get like a little sort of electric shock, essentially, but a little buzz in your back. And the idea is that it confuses the pain fibers that are going up to your brain and takes that edge off. And it works particularly well for people in early labour. That's who we recommend it for. And if you start it early enough and keep going with it, you can go through a whole labour, and it really takes that edge off. Another one is sterile water injections. So this is something that some of the midwives do, and it's basically essentially what it's like is having a little bee sting. And I know because I've gotten curious before and actually had these just to sort of test out and see what it's like. But basically a little injection that goes just under the skin, literally right under the skin, and then it's a sterile water bleb under the skin, and it feels like being stung by a bee. It's horrible. But the idea is that you have a couple of those in your lower back, and that kind of, again, like this sort of gate theory of pain where you can't have all these pain fibers going up at the same time. The idea is it confuses the whole thing and kind of works to reduce your pain. So look, it's not for everyone. The evidence is probably up and down, but at the end of the day, having these kind of tools and thinking, what can I do that's natural, can be really helpful. Let's see, what else have we got on here? So gas, that's a classic one. I see there's another couple of questions there. I'll jump on and answer those in just a minute. So gas, so we offer nitrous, which is essentially laughing gas. Okay, same stuff you get at the dentist, and works really well in labour for some people, basically. Okay, so some people swear by it and they have this fabulous labour and they just use that. And the idea is it's very short acting. It only works while you're breathing it in. Okay, we can dial up the amount of actual nitrous in the mix, and then as you breathe, when you breathe out, when you stop doing it, then it sort of wears off. So really you do it during a contraction, has no impact on your baby, and then between contractions you stop breathing and you feel fine. Just gives you a little bit of a spaciness during the contraction. It might be enough to knock the edge off your contractions. Then we sort of move into the more sort of medication route, okay? And the medications we typically use in pregnancy would be Panadol, good old-fashioned Panadol. Really actually works bloody well. So having that, loading up on that early is really good, and rather than taking it when you need it. We can move into the stronger stuff then. So endone, which is a tablet that gets metabolized to morphine, is a good tablet. Now, we want to avoid that if you're really close to having a baby, because it does cross the placenta, okay, and it can make your baby a little bit sleepy. So if you're 6, 7, 8 centimeters dilated and you've got a lot of pain, we'd probably avoid the opiate medications. And that goes for the other one, which is your morphine injections. Some of the hospitals will give you a little, what we call a subcutaneous little injection of morphine, okay, and it takes the edge off your pain when you're in labour. Again, we can do that, but we just try and avoid it right before your baby's born. And then we get to the big guns, okay? And we've talked about all the other medication things, and then if you really want to get in for a one-stop, knock off the pain thing, it's your epidural. Your good old-fashioned epidural. And these days, epidurals are, like, they're better than they used to be. So there's all sorts of epidurals, lots of different options they've got in medication-wise and things. You've actually got probably a little bit more mobility than you used to. But basically what happens is it's an injection in your back, in your lower back, goes into the sort of fatty tissue around your spinal cord, and then we can put a catheter in there and give you a button, and then that can stay in for the whole duration of your labour. So you can go there and you can press it whenever you like, okay, and every time you need a little bit more pain relief, you press it, and it'll just keep that pain relief coming. And the idea is it sort of numbs everything from about here down, okay? So it works really, really well most of the time. Obviously, some people have complications in that it only kind of works more on one side. It's a bit patchy, it wears off, all sorts of things. So that it's not, 100%, but certainly if you want to take away the vast majority of your pain in labour, an epidural block might be for some people. Someone who's got an epidural, if they do end up, for example, needing a caesarean section, then it might be that they can just top that up rather than having to go for, say, a spinal anaesthetic. I guess some of the things people worry about when they hear about an epidural is whether or not it's going to increase the chance of having, say, a forceps delivery or something like that. You've got to tease out a little bit why the epidural went in the first place. Is it because you've been pushing for 2 hours and the baby's head hasn't moved and we're thinking we might need to do a forceps, therefore we get an epidural? Or is it we put an epidural in right when you started and you've got a bit less sensation, so pushing becomes more challenging? So potentially, if you can't have as much sensation, then you might end up not pushing as effectively, but with some really good coaching from some of our fabulous midwives and doctors, you should still be able to push the baby out, no problems. So that pretty well covers all of those pain relief options. I've got another couple of questions here. Let me have a little look. Is it safe to have an epidural with a VBAC in terms of rupture and not feeling any early signs of pain around the incision site? Yeah, look, that's a really good question. The sign of pain around the incision site is a tricky one, because if you look at the evidence, certainly it's a sign that something's going wrong. So if you have scar pain, that's certainly a concerning feature. A lot of people do get some degree of lower abdominal pain, but that doesn't necessarily mean it's all going badly. So I would suggest, I would never tell someone not to have an epidural if they're having a VBAC, because we would miss this sign. There's lots of other things. We're looking at your baby from so many different ways and your labor that we're going to pick up other signs, okay? So be it bleeding, be it a poor progress in labor. You know, we go 2 centimeters, 6 centimeters, and then instead of going to 8 or 9 centimeters, we stay at 6 centimeters. Little things like that are a really good indicator that things are going wrong. If you've gotten to the point where you've got so much pain in your scar, then that's a really late stage thing. So I would be, pretty worried at that stage. So I would not suggest that epidural is any contraindication. Be happy for you to have an epidural if you are having a VBAC. Let's have a look here, see what else we've got. So in terms of fentanyl and sphincter of Oddi dysfunction, that is a really good question for an anaesthetist. I can't answer that one for you. It's not my specialty, unfortunately. So what you want to have a chat with is the anaesthetic doctor that's going to be giving you the, your epidural or your spinal anaesthetic using the opioids, and whether or not that's going to change your pain, unfortunately. Okay, Jackie's saying, is there a calm birth version of a C-section? I think I saw something online about things you can do to make it feel less surgical. So thanks, Jackie. So unfortunately, I guess, assuming you're not talking about a maternal assisted caesarean section here, which is kind of what we've been chatting about. I think if you're talking about like a calm birth version, like how you set up your birthing room to have, low lights, candles, all that kind of stuff. Unfortunately, we don't have that yet, okay? Watch this space, but at the end of the day, there's a reason why operating theatres are really big, bright lights, okay? One of my colleagues went to Papua New Guinea to do a medical term over there, and she was doing a caesarean section, and the generator, well, the lights in the theatre, mid-caesarean section, literally went off. The generator was broken, and suddenly they were in the dark, and she sent me this incredible video of doing a caesarean section with 4 people holding iPhones with the torches of the iPhones, and there she finished the caesarean section, about 20 minutes of surgery with literally the light of 4 iPhones. And I gotta say, as amazing, as incredible that was, and I'll take my hat off to her, it's not like a situation I'd really like to be in. So we're not going to probably get to the stage where we can turn the theatre lights right down and do a really sort of dim lit type thing. And unfortunately, the operating theatre is quite a sterile environment. But if you look at it the other way, you really want your operating theatre to be a sterile environment, because we are still talking about major surgery. We are still talking about going into your abdomen, and there we do not want bugs in there. So there's a reason why we've got to keep it, unfortunately, pretty sterile. I like to try and set up the environment in the calmest way I can. For my private patients, I always ask, what's a playlist you want to play? We can get the music going. Try and keep the chatter to a minimum. Try not to sort of gossip with my assistant while we're performing the Caesar while you're awake there. So we do try and do everything we can to make it a nice, calm environment. And certainly, I guess one of the advantages of a maternal assisted Caesar is that we go into that operating theatre trying to provide a really nice birthing experience. I think it actually probably just switches something in everyone's heads in the room, where it becomes a lot less just, oh, this is what we do every day for work, but we're trying to make this all about the mum. And I guess that's what we're trying to do in a maternal assisted Caesar, is just bring it back to being all about the mum. So that's probably not a bad place to finish up. I don't think there's any more questions there at the moment, which is fine. So I'll sort of wrap it up. So tonight we talked about If you haven't seen it, if you want to go back, it's going to go up, I think, on a few different places. But we talked about VBAC, so having a vaginal birth after caesarean section. We talked about this fascinating sort of trend of maternal assisted Caesars, something I'm really passionate about and like to offer my patients. And then we talked about some pain relief options as well, which hopefully has given you guys some, if you're a prospective mum, if you're thinking about getting pregnant, or you're currently pregnant, or you've been pregnant before and you're thinking about getting pregnant again, hopefully some of these things we've talked about kind of get you excited and enthused about pregnancy. Like I'm excited and enthused about pregnancy. I love what I do. I want to share that with you guys. That's why I'm here doing this. So I would really encourage you to reach out. I'm really approachable. As I say, for a first appointment with me, I never charge anyone any money for that. So if you're thinking about obstetricians, please feel free to get in touch with my rooms, make yourself an appointment, come in, say good day. You got to spend 7 months with your obstetrician, right? By the time you book in at 8 weeks, it's 7 months. We see you a lot. You want to get along. You want it to be a cool vibe. And you'll know when you meet someone. You sit down in the room, meet your obstetrician for the first time, you'll know straight away whether this is a person you want to be with you for your journey. And I hope that by sort of showing you some of these tips and tricks tonight, that sort of could be someone like myself. But as I said, I've got to put in a plug for the whole hospital. They've been fabulous putting this on. And we're just so lucky that we live in an area where we have almost every single one of my colleagues is just the most fabulous doctor, so you can't really go wrong. And you're very lucky. The midwives are incredible, the theatre teams are incredible. So you live in a great area, and so yeah, big thanks to everyone tonight. I've got to extend a really warm thank you very much to the Northern Beaches Mums group for having me on. I really appreciate it. It's lovely. I mean, you guys are a fabulous group, providing so much good information. As I say, my wife's on there with my 2 beautiful children, and she's on the group all the time. She gets a lot of information from it. It is a fantastic resource for all the mums of the Northern Beaches. So keep it up, guys. It's a really, really nice community. I'm just so privileged to be part of it. I will put in another plug for my Instagram. As I said, if you want to jump on Insta and check it out, it's Dr. Dr. Hugh Porter. As I say, I'm always popping up just pregnancy tips and stuff. I also respond a lot of times to messages and things. So if you want to get offline here and send me your question about your situation, then absolutely get on there on Insta and send me a message. And look, yeah, basically, best of luck with your pregnancy, whatever that involves for you, whatever your journey looks like. I hope it's the way you want it. And if it's not the way you want it, I hope we communicate well enough with you that makes you still think it was a really nice experience. So I think we'll leave it there for tonight, guys. Thank you so much, and good luck.